Hello. Oh, it seems like we have lost Melissa this morning. Hi everyone, my name is Jessica Salzwedel. I'm a program manager at AVAC, and we are watching the series today as part of the Research Literacy Networking Zone. Normally we would have all been together at AIDS 2020 in San Francisco this year. Unfortunately, given the global pandemic, we are unable to be together in person, but if there is a silver lining, perhaps it's that the global village this year is truly global, and we are able to connect broadly using these virtual platforms. And so today, we have a very exciting conversation on long-acting injectable PrEP in cisgender women with the actual PI of the clinical trial, Sinead Delaney-Morletwe, from Wits RHI in South Africa. So I am going to hand it over to Sinead and Awilani, who is going to help us navigate this conversation. But I do like to start off with that we want the conversation to be participatory. We are live streaming on both AVAC's Facebook and on Wits RHI Research Connect. So we will be fielding questions from both locations. But we also want to make sure that you on the actual Zoom line today have a chance to ask questions. So please feel free to use either the chat or the Q&A function so that we can go ahead and ask your questions directly to Sinead today. Great, and just so everybody does have a background, her bio is there and we can read it, but Sinead is a professor and the director of research at Wits RHI at the University of Witwatersrand in Johannesburg. She's South African-born medical doctor, and her research has focused on the intersection between sexual and reproductive health and HIV, especially in adolescents. I think this conversation is both so timely. We are a year post-ECHO. This conference at AIDS 2020 has brought us results in MSM and transgender women, but not in cisgender women yet. So this is a really wonderful opportunity to explore what this trial means, not just for long-acting cabotegravir, but perhaps what it can mean for PrEP and young women. And it also obviously comes as the UNAIDS report just came out, and we hear once again that 1 in 4 women in sub-Saharan Africa are the source of new infection. So 15 to 24 and overall 15 to 49 make up 50% of the new infections of 2019. So this is an incredibly timely topic and research. So Melissa, I don't know if you want to introduce Awilani before we just start the conversation.
Thank you, Jess. Awilani Naluwande is a youth CAB member based in Joburg, South Africa. She is very passionate about HIV prevention issues, and she is at the forefront of leading the fight against HIV prevention, as I said, as a community representative. And she will also be leading us in the discussion today, asking Sinead questions about the study and raising some concerns as a young woman on the ground about some of the issues maybe that are coming up. So yeah, over to you, Awilani.
Okay, thank you very much, Melissa. Am I audible?
Yes, we can hear you.
Oh, okay, I'm not used to sight. Yes, thank you very much for the platform as well. I really appreciate it. So to begin with, hi, Dr. Sinead. It's such an honor to be interviewing you, first of all. Yes, it's a privilege.
It's an honor to be interviewed by you.
Yes, so should I begin? All right. So I guess to just kickstart, you can just maybe start by giving us an overview of the study, both the HPTN 082, 083, and HPTN 084.
Thanks very much, Awolani. So both HPTN 083, which is a study in cisgender men who have sex with men and trans women, and 084, which is the study in cisgender women, are phase 3 trials that are aimed at answering whether cabotegravir, particularly injectable cabotegravir, is effective as PrEP, safe and effective as PrEP in these populations.
Okay, thank
so
you
they're
very much.
essentially similar trials, but they do have some differences.
Okay. Would you perhaps like to take us through the differences, maybe?
Sure. So in terms of the differences between the two trials, obviously I've mentioned the population. I think the other thing is that the design has been different, and this is relevant for some of the results we've heard. The 083 trial was designed as a non-inferiority trial, whereas 084 was designed as a superiority trial. These are statistical terms, but what the important thing was that when the trials were designed, we had much more data on how well PrEP worked to prevent HIV in men who have sex with men, based on the placebo-controlled trials compared to women. So the original question that 083 asked was, is cabotegravir as good as Truvada? Whereas in 084, from the beginning, because of the wide range of results that we had for the effectiveness of Truvada in the placebo-controlled trials in women, we always had to start with the question, is cabotegravir better than Truvada in terms of our statistical design?
All right, thank you very much. I'm talking about the two drugs that are involved in this study as a whole. Would you perhaps also like to take us through the two drugs, CAB-LA and then ECAB, and also Truvada on its own?
Okay, so Truvada is actually two drugs, tenofovir and emtricitabine. Sometimes you hear us talk about FTDF or TDF-FTC. That is an antiretroviral drug and is used both in treatment but also in prevention. It works on some of the, it's a non-nucleoside reverse transcriptase inhibitor, which means that it inhibits some of the enzymes that are involved in HIV replication, and it interrupts that replication so that HIV infection can't get established. Cabotegravir is an integrase inhibitor, so it operates on a different enzyme involved in HIV replication, but essentially it's also an antiretroviral. It is also being developed for treatment as an injectable agent, and in fact has been licensed in Canada in combination with rilpivirine, and is also being submitted to the FDA. So both of these drugs are used both in treatment but also would be used for prevention.
Okay, thank you very much for that brief overview. And then moving on forward, we're going to talk about the study, right, as a whole, which is where my interest is as a young woman based in South Africa, especially right here at the heartbeat, not really the heartbeat, but in central Johannesburg. You know how things are the side. So I just want to find out what is the whole aim when you targeted that population? Because according to what I heard, is that your targeted population is young women from the ages of, just clarify that for me, the age population, as to why did you choose that particular age population as a whole?
That's a great question. So the important thing about these trials is that they're phase 3 trials. What that means is that's the final step in proving that they work. So it's really important that in order to prove that they work, that they're evaluated in the populations that are at risk for HIV, so that if you show that it works, you can show that it works in the population that you want to use these products in the future. And so it made sense given, I think, Jessica's introduction as well. We know that women in sub-Saharan Africa are at high risk for HIV. And we know particularly that young women, sort of between the ages of 15 and 24, are at exceptionally high risk for HIV. So if we want to prove that these drugs work, it's really important that we evaluate them both for their safety as well as the fact that they work in the populations that we anticipate will use them in future. But also, to get a result fast, it's useful to do these trials in populations where you know there are high rates of infections, so that you can get an answer rapidly that can then mean that these products can be used in the places where they're most needed.
Thank you very much for that. I guess you also answered my second question. And then now moving on forward, I just want to talk about, since the study, the clinical trial study is basically up and running, what is basically the benefit of those young women that are basically participating in it, you know? And since it's still up and running for those that are there, because even I as a young woman, if I were to basically participate in it, I would want to know, what is it in for me? What is it that am I getting into this? What exactly is the main benefit for these young women that are basically saying that we are taking a stand, or we are taking a chance to say that let's take a leap of faith, let's see where this drug takes us at?
So again, it's a great question, and it probably has several parts to that answer. I think the first thing is that when we do these trials, we expect something called scientific equipoise, which is that we mean that the potential risks associated with taking a product are balanced by the potential benefits. And we say that we don't yet know whether this will be beneficial, but we think that the potential benefits are in balance with any risks that may be associated. And remember that this is a phase 3 trial, which means it's gone through a lot of evaluation already, and we have a lot of data to say that to give us some understanding of what those risks might be, and make sure that we don't enroll people who might not benefit from the interventions. So when people join these trials, these are the things that we explain in the consent forms, and we explain to people who can join, what might the potential side effects be that they might expect, what are the kind of mild side effects, what might the serious side effects be, and how would we manage that. And so I truly think that the benefits to participation are that it is an opportunity to have access to regular clinic services, regular HIV testing, regular counseling, regular support, but also in this trial now, we know we have one arm where we know that that drug works to prevent HIV infection, that's TDF-FTC, and we have a strong belief that this other drug could work to prevent HIV. So potentially everyone who joins the study might have the potential benefits of a reduced risk for HIV, because we don't have a placebo in this trial. So those are some of the reasons that people join trials. But I think sort of for us, the most important thing is participant safety. And so anyone who joins the trial, the point is that we communicate very clearly what it is that they're getting into, so that they get into it with a clear set of intentions.
Thank you very much, Dr. Sinead. So you spoke about the fact that this drug has been tested, right, through the HPTN or 83 study. We got the results. I even watched the interview on YouTube, yes. And then I guess one of my concerns was the fact that it's tested on a different gender, right? And here we are testing it on women. So I think my greatest concern would be, what if, as much as it's tested, what if PrEP doesn't work effectively in women? Then what then for those participants? What does it mean moving on forward in terms of the prevention of HIV and AIDS?
So I think those are great questions, and I think the 083 results already provide some insights. I mean, you saw in the 083 presentation that there were 52 incident infections. So I think the first thing is that even with very good drugs, there may still be reasons that they fail. They're not 100%. They can be very effective, but not 100% effective. And this is unfortunate. And you will see that in the TDF-FTC arm, there were more infections than in the CAB arm, but there were infections in the CAB arm. And the investigators involved in that trial are working very hard to get all the information together to understand the drug levels. So were people taking their drugs, or was there some issue with the drug levels when they became infected, that they didn't have sufficiently protective levels? Or is it because they encountered resistant virus? So all of this information would help explain why some people became infected. But I do think that what is very impressive from 083 is that they still had incidence rates far below what we see in the absence of PrEP. I think Jessica mentioned the ECHO trial, where we saw an incidence of about 4%. We heard the HBTN 702 trial results, where in women there was an incidence of 4%, with a very low background rate of PrEP. In these trials, we're seeing incidences of around 1%. We'll see what happens in the 084 trial, but I think the point is that we are learning that PrEP definitely works to prevent HIV infection. And so if we do see infections, it will be important for us to understand why, so that we can address some of those issues in the next generation of products that are developed. But of course, this is why we're asking the question. We do want to know whether it works in women.
Yes, true. And then now that you basically touched on infections that did take place within the 083 study, it will be at best interest to basically me ask you that, should there be any rising infections in the 084 study? Have you guys basically worked around how will you control the infection rate to work around it? Because like you said, each and every drug that is tested does have percentage or chances of failing. So let me just say, should I, as a participant who is enrolled in the study, should now at this particular moment, hearing the fact that in the 083 study, there were people that tested positive, and should I be one of them who test positive? And then what is the way forward in terms of you dealing with those particular cases?
So I think for many HIV prevention trials, not just 084, there's always been a strong attention to what happens to people who do seroconvert. And obviously these are very unfortunate events, but they occur in the context of ongoing HIV infection in these communities. And I think the participants in the trials often experience a lot of additional benefit in terms of access to preventive education. But some infections are not preventable. And in those instances, I think what's been important is that in the trials, we test regularly. At each visit, participants are tested. And so as soon as infection is detected, we have an opportunity to link those people to care so that they can access the benefits of antiretroviral therapy. Now, one of the important questions that has come out of 083, and I've already mentioned it, is that it's been important to know the resistance profile of any of those infections, to just make sure that the people who were on either Truvada or cabotegravir are put on antiretrovirals that we know will lead to viral suppression. And what I've understood from the conversations with Dr. Landowitz is that all of the people who've seroconverted in 083 have had a good clinical and virological response to their antiretroviral therapy. So that is very reassuring. And the same processes are taking place in 084. Obviously, we are blinded and we don't in fact know how many infections we have currently, but our DSMB does. And they would be the ones to tell us if there were any safety concerns, including that the drugs do not appear to be working and there's no benefit of this trial.
Thank you very much for that. So I can see that we have questions on the chat. So I'm just gonna pick one question or two. It would depend. Yes. So I will take one question from Jessica. So she's asking that, can you talk a little more on what superiority versus non-inferiority means in the real world? What could it mean if CAB is superior to TDF? So I guess this is where the comparison comes in.
Well, I think it depends on your perspective, but essentially sort of when we do non-inferiority trials, it's often because to show superiority means that you may have to have a very large trial. So non-inferiority trials basically say this product is not worse than the existing standard of care. Whereas a trial that is designed as a superiority trial says this product is better than that one in preventing TDF-FTC. But what it means for individuals might be quite different, because to some extent, it is about sort of what suits them at their life stage. I think that what we believe is that the advantages that cabotegravir has over TDF-FTC are not anything about the molecules themselves. They work well to prevent HIV replication. The value is in the delivery strategy, that getting an injection every 8 weeks optimizes adherence over taking a pill a day. And so that's probably where the benefit lies. And we'll learn a little bit more about that when we see the drug levels and the resistance profiles that tell us, kind of when people did get infected, was it because they weren't able to take their pills every day?
Okay, thank you very much for answering that question. And I guess, as a young woman, if I were to take any drug at all, like I would basically have concerns with regards to safety and the effectiveness of the drug when it's in my system, And then I'm going to take another question again from Jessica. It says that, can this trial tell us something about oral PrEP, especially about the adherence of oral PrEP? So you did touch a little bit on that, but then you can as well emphasize again.
Yeah, so I think what we've learned from 083, they anticipated that over the course of their study, about 67% of people would, there would be about 67% adherence. So people would take 2/3 of their doses. And remember that some of the data from the placebo-controlled trials had said that there is some forgiveness when it comes to missing pills, when it comes to prevention of infection via the rectal route. So, kind of that seemed like a reasonable assessment. What they in fact saw in the drug levels that they took in a subsample is much higher levels of adherence than they anticipated. And I think that what that tells us is something that we sort of learned post these placebo-controlled trials, which is that when people know a drug works to prevent HIV infection, they're highly motivated to take it. But even so, kind of there may be some missed doses. So those people represent averages. But what we then need to do is look at all of those people who had infections. How many of them had detectable drug? And, kind of will we find what we've seen, I think, in other demonstration projects, which is often that people don't have detectable levels of drug at the time that they acquired infection. And for the cabotegravir and those infections, it's a very interesting story that's emerging, and really kind of we need that drug level data to understand some of these infections, which appear to have been acquired very early on, and maybe because of some uncertainty we have about at what level you get protection when you're taking the oral cab, because a number of those infections occurred in the oral lead-in stage. And a bit like how we tell people, look, you need to take Truvada for 7 days before you will acquire the full protective benefit. It may be that for CAB, kind of some of these early infections occurred because we hadn't achieved the levels needed to get protection.
Okay. Thank you very much. And then I'm taking again another question. I think with this question from Melissa, I will take it, but not now, because I also have a question based on that as well. And then I'm going to take a second question, which is if CAB LA is superior to oral PrEP, and the reason for the number of infection in the Truvada arm may be due to the adherence, and Truvada is known to be 100% effective when taken accordingly. Is this conclusion about the superiority valid? So I guess you did just answer on that, but then you can still go ahead.
Yeah. So I think, look, it is complicated, and I think sort of the bottom line is that, just to recap, that even with very high levels of Truvada use, we don't see 100% protection. It's very high, but it's not 100%. So I think that's the first point. But the second point is that we think that the differences between the two drugs are driven by adherence. But so it is that the benefits that we see of CAB are not about the drugs themselves, but about the mode of delivery. But I think the third point about, is the trial result valid? Yes, I think this is a separate point, which is useful to emphasize, is that these evaluations were done in a randomized manner, just to remember that this was a double-blind, double dummy, which means that everyone got a pill and everyone got an injection, and no one knew whether they were getting active CAB or active Truvada. And so the differences that might be seen are not due to people taking just injections and not taking pills. They got to take both throughout the trial, and then we unblinded and looked at the differences between the two groups. But everyone, while they were on study, didn't know which active arm they were in. So they were encouraged to be adherent to both injections as well as pills throughout the trial.
Okay, thank you very much for answering those questions. I guess now, as a young woman, should this drug be rolled out? One concern that I have now that we're basically talking about the adherence and everything that has to do with dosage, I'd like to ask, what happens if it happens that I miss my dosage? Because there are certain things or measures that can lead to one missing a dosage, you know. So I just want to know, if should it happen that I miss my period to take that particular, let me just say, to go for my clinical testing day or whatever the case is, what happened overall if I just miss a dosage?
Yeah, so you raised some great questions there. I think on the issue of oral Truvada, you know, we do have some data that suggests that we need to have higher rates of consistent pill taking in order to protect women or cisgender women who will be infected via the vaginal route. That this probably has to do with the levels of drug that are achieved in the genital tract tissues. So missing, you know, more than several pills can lead to lower concentrations of the drug in the blood, and that can put people at risk that if they're exposed to infection, that the drug may not be sufficient to prevent HIV replicating. So it's always been important for us to affirm that for young women, they need to be consistent with their pill taking during periods of risk. But we are learning a lot about that in open label demonstration projects, that people are quite good at assessing when they have risk periods and when they don't. I think just the important thing is that it's probably not good to cycle on and off just because there is a period during which we need the drug levels to achieve a stable concentration. And then for that period, you will have protection. And if you're always dropping on and off, you can, you know, maybe not have the levels that are needed. But for example, if someone doesn't have a sexual partner for 3 months, may not make sense to take pills during that period. But when you are sexually active, then, you know, daily pill taking is probably the way to go for young women. With cabotegravir, we provide injections 8 weekly. And people have asked, why can't we make this 12 weekly? Because then it would line up very nicely with the depot injection for contraception. And this is a question that has been debated. We know that in women, we achieve longer concentrations. This also relates to, I think, a question I saw in the chat about the tail. But once women have received a couple of injections, as long as they have injections regularly, they will maintain very high drug levels, such that if they're a bit late for their injection, there probably still is some protection. And in fact, we've used that information to help us during COVID to say that if you cannot come into the clinic in 8 weeks, at least try to come in by 12 weeks, because we think that there's enough forgiveness in these injections that, you know, we probably can go a bit longer. And the last point is just to say, well, why didn't we answer this in 084? And the reason is we really wanted to go for the safest possible way to get a result, knowing that if we could show that it worked 8 weekly, we could then do the studies to show that it works 12 weekly. But if we did it 12 weekly and people then were late for those visits, we might have a harder time demonstrating that CAB worked. So going 8 weekly was the safe option, but we do think there may be the potential in the future to extend the interval out a little bit further.
Okay, thank you very much. Talking about cisgender females or women, I would take the question that was raised by Melissa again. She says, were there any safety concerns identified by the DSMB for cisgender women?
Great question. So the DSMB met in May. They said they had no safety concerns, and so supported us continuing 084 because they think it's an important question and we need to accumulate the data to answer the primary question about the safety and efficacy of CAB-LA for cisgender women.
Okay, and talking about safety concerns as well, it just rang in my mind that as much as we spoke about CAB-LA, we didn't really specify a lot on any side effects of the drug, because I'm like, it's an ongoing study, meaning that should there be any side effects towards it, you should have maybe data to state that when a person takes the drug, this is what happens. Because when I went through the HPTN 083 trial results, they did say that CAB-LA, according to their study, based upon men who sleep with other men, and yes, they did emphasize that it does cause high blood pressure. I don't know if that also plays a role when it comes to the 084 study. So just also touch on that as well, on the side effects that one can encounter when they're within the study.
Yeah, so good question. When people enter the study, they do get a long list of possible side effects to expect. From the early studies, so HPTN 077, we had seen that there might be higher rates of headaches in people who had taken cabotegravir, as well as injection site reactions, so pain or itching or redness at the site of injection. There are also a range of effects that people may experience, but they're in the trials, they had not been different from placebo. But often when people start a new medication, they may experience some effects that are associated with that. So things like headache, nausea, gastrointestinal upset, those don't appear to be higher than placebo, but kind of these are important things to kind of sensitize people to. In the 083 study, when they looked at the grade 2 events, so events that were specified as being important, the difference is that they actually saw then excluded high blood pressure. That in fact the things that were significantly different from TDF-FTC were that they saw more injection site reactions, nasopharyngitis, and fever. And the fever was usually within 7 days of injection. But no longer any differences in high blood pressure. There have been some differences, in fact, in higher rates potentially of glucose levels in the blood. And then in the Truvada arm, they saw potentially people more likely to have the higher rates of sort of abnormal blood levels, suggesting some effects on kidneys, which we already knew about. So this is sort of what we know. The biggest concern about cabotegravir going into these trials was the potential effects that that might have on the liver. And this is something that we've monitored very closely in the trial, but it's really reassuring to see that in 083, in fact, there have been very few concerns about the liver effects. So that's something very positive.
Yes, thank you very much for also emphasizing on that. I'm also going to take your question again. Here there was a question with regards to the tail, which is something that I've also heard about, but then I also need clarity. Yeah, so let me just check it. So this is a question as well from Melissa. It says that, can you talk about the CAB-LA tail? Should young women be worried about this tail?
Yeah. No discussion about cabotegravir is complete without the tail. And the tail is this this effect that we see, that when people stop taking their injections, they have levels of drug which will decline over time. And the concern is that as that drug level declines, it will reach a level where if you become infected with HIV, that drug level is not sufficient to prevent infection. And in fact, what it may allow is then HIV to take hold, but the HIV that takes hold is in fact HIV that is resistant to cabotegravir, because in the same way as an antiretroviral therapy. If people don't take their pills regularly, they can develop resistance because they have some drug there, and the HIV viral variants that succeed are the ones that are able to mutate and avoid the antiretroviral drug like cabotegravir. So just to say, it's a theoretical concern. It's not something that we have yet observed, but in order to kind of manage that theoretical concern, when people finish their injections, either because they've come to the end of study or because they choose to stop their injections, and one specific instance in 084 is in fact when they become pregnant and we're required to stop injections, we ask women then to take Truvada, TDF-FTC, and it's to cover the tail. That means that while the cabotegravir is declining, they still have a sufficient level of antiretroviral that if they encounter HIV, that HIV would be prevented. Now, in women, we have seen data, it was recently published, the 077 data, showing that in women, many women have a very long tail, that, you know, kind of a significant proportion of women beyond 1 year may still have detectable drug. And we really don't know what this means practically, because in real life, what we imagine is that people will use PrEP when they have periods of high risk, and they will stop using PrEP when they no longer think they're at risk for HIV. And so if you're not at risk for HIV, if your drug levels are declining and you're not going to encounter HIV, it's not a risk. So it's really just the messaging around whether or not you continue to take another form of HIV prevention while these drug levels decline, and a better understanding from the 084 trial of how long these drug levels persist in order to advise women how long they may need to be aware that they may need to use effective prevention measures if they stop taking an injection.
Thank you very much for putting emphasis on that. We have questions now in our Q&A section, and then I'm just going to take those 2 questions that are there. So the first question is from Melody Jobert. It says, what happens if participant does not want to continue in the study after learning of the HPTN 083 results because they think they are getting placebo CAB-LA?
Well, that's an interesting question. I think that firstly, anyone is able to withdraw their consent to participate in the study at any time, and there are some people who have. When they do and they've taken injections, we do talk to participants about the tail and the idea that they need to continue to use a form of HIV prevention for at least a year, either TDF-FTC. And some participants have then said, well, yeah, I want to stop taking injections, but I will take oral PrEP, and they stay on study. But some people can leave. I think to this particular question, the important thing to remember is that we've seen a great result in men who have sex with men and trans women, but we don't know whether that translates into a benefit for women. And that's why we're continuing the 084 trial, because we are not sure. There are reasons to suspect that the results could be different. We wouldn't want it to be that way, but we need to prove that you can also protect women against HIV acquisition using CAB, and that it's safe to do so. And so these are the conversations we would have with participants. But in the end, if someone wants to leave the trial, they're entirely entitled to do that.
Thank you very much. And then there's another interesting question from the Q&A section again from Yvonne Miyawa. So so the question says, do we anticipate for more related studies with variety of options for young women and adolescents?
That is a great question. I can answer about cabotegravir, but also I think there are other products that are under development that are very exciting. So once we answer the main question from the 084 study, one of the important things that we would like to do is also to be able to say that these products are safe to use in people under the age of 18 who may be at risk for HIV. And so there are two companion studies, HPTN 084-01 and HPTN 083-01. They are sibling studies, or rather they are companion studies that are aimed at enrolling a much younger population, adolescents. They're open label studies, but they are essentially aimed at showing safety and acceptability and also pharmacokinetics of CAB in these younger populations, so that when cabotegravir is licensed, it can be licensed for use in a broad range of people and not just people above the age of 18.
Thank you very much for answering that. It would be very lovely to have a variety of options, especially looking at this day and age that we live in, especially looking also at the high rate of gender-based violence that is increasing rapidly in our country. I, for one, as a young woman, would really love to have even more further options. And then lastly, I'm taking a question from Sindra. Her question says, how long will women be monitored for the tail?
So that's a good question. In the 084 trial, step 3, the step that happens after you stop taking injections, is 48 weeks, like it is for in 083. But what we are anticipating is similar to what's happened in 083, is that we will come to a point at which we will demonstrate benefit, and instead of everyone, we have the potential to demonstrate benefit, and instead of everyone switching over to 48 weeks of cabotegravir, we may be able to switch into an open label demonstration project which follows people up for a prolonged period of time. During those open label extension studies, we would be able to monitor people who may have stopped injections for a prolonged period to see how long, in fact, the tail does last, and also whether the hypothetical concerns about resistance are in fact confirmed. But ultimately, I do think that what we will need for moving forward with these long-acting drugs are strong pharmacovigilance systems that do allow us to continue to provide monitoring to people who've been on injections, so that if they are exposed to HIV infection, we are able to make sure that they get access to antiretrovirals. And this is part of the sort of expanded program. So maybe just to be clear, in the real world, if we show that 084 works, and if it eventually gets licensed, there will need to be a system in place that is able either for people to stop injections because they're no longer at risk, or to stop injections and to move to another method of HIV prevention, and to continue, if necessary, to seek regular HIV testing if they do have unexpected risk. And so we will need a whole system. And then, you know, if we do see that with large numbers of people taking CAB, that there is this phenomenon, you know, we will need a pharmacovigilance system to actually detect that. So these are some questions that the trials can gain insight into, but ultimately, you know, it will be the health system that will need to figure out how to manage large numbers of people who are using CAB-LA if this tail is a concern.
Thank you very much for answering that as well. So there's also another question that was just sent right now from Nandi. So she says that what has been the response of the participants to the HPTN 083 study results, which I've also heard people in the youth camp also raising concerns about it, especially the accuracy of the results as well. So it would be very lovely for you to basically share more information about it, especially looking at where the HPTN 083 study research took place, and looking at where we are basically situated like in Africa right now. So the accuracy of the results is also one concern that other people have in terms of putting it into our real world where we are right now. So just emphasize on the response of the participants. That is, if you have received any response from them, yes, and then just highlight on that.
Yeah, so as you can imagine, after the DSMB in May, the first set of points that we could communicate to participants was this idea that cabotegravir is effective in preventing HIV, And at the time it's as good as TDF-FTC. So since then we've had an update, which is that it may have been more effective than TDF-FTC. So when we first got that information, we do something called a Dear Participant letter. And this was drafted and is communicated with all participants as part of their participation in the trial. It's an opportunity to reassure people that there's no safety concern, but that this is a potential benefit, which in fact may enhance their enthusiasm to be part of the trial, because now, whereas before we had no human data that CAB actually worked, now we have some data, and so we have the potential to demonstrate benefit. We've communicated this to participants, we've communicated this with community groups, we've communicated this with activists, and so far I think that we have had a lot of support for the importance of continuing this trial in women. I think, to your point, many people know about the huge risks that women in Africa face, and have seen the importance of generating this data in women so that we can license this product for use in women. And I think what's fresh in people's minds is the FTAF experience earlier this year, or last year, where the FDA licensed FTAF for use basically in all populations except those at risk for HIV through vaginal sex, thereby excluding cisgender women and prompting the need for another trial. So I think that there is strong support for us to continue 084 to get a clear result, despite some of the challenges that I think our region is facing. And I think maybe to speak to your concern that I think I heard, which is about generalizability of 083, that was a really large trial conducted in the US, in many countries in Latin America, in South Africa, and in Thailand and Vietnam, so representing a broad diversity of populations. And so I think and a very large trial, and I think that the results are robust, and people should feel confident that the result that was generated is a result that will be that will be viewed by regulatory authorities in a very positive way, because it was a very well conducted trial.
Thank you very much for answering that as well. So basically, for me as a young woman, based on everything that you just said, I would say that it is of great importance for you also as a scientist to ensure that each time when you run the clinical research studies, it's very important to ensure that you understand the needs of us. Let me just say, I don't want to really say young women, but then women as a whole, so that whatever clinical trials that you are running also align together with the needs and wants of us young people, Yes, I would definitely talk for the young women that live in Hillbrow. I would definitely do that, because that's where I'm based, yes. And then moving on forward, because I see that even we are also about to reach the end time. So I'm looking at the time as well. There's a question that was raised with regards to COVID-19, right? As to how has COVID-19 impacted the 084 trial? Is the data still okay? Because, yeah, that is a very great... should I say concern, because a lot of things were put on hold during the lockdown phase that we had. So now one can only just wonder, is the data still accurate even up until now? So over to you.
Yeah. So I think everyone was worried about the impact of COVID on these trials. Just to say that we as a team put together a number of measures early on. We anticipated the potential site closures that a lockdown might precipitate. And so in early March, we actually developed guidance for sites and distributed that ahead of lockdowns about ways to kind of manage participant visits. When the lockdowns happened, very few of the sites had to close. Most sites were able to stay open with healthcare worker exemptions, and so kept going during the lockdowns. And have kept in touch with participants during the lockdowns. One of our biggest concerns was participant safety, but also staff safety. And so a lot of measures have been put in place to kind of ensure that. So avoiding public transport, and bringing participants to site, doing screening before bringing people onto site, you know, kind of having reduced numbers in clinics, managing the visits that way. And we also have had both through trial sponsors and other mechanisms, donations of PPE for both staff, but also for participants when they're in the clinic, that they have masks and things like that. So there's been an enormous effort to ensure both participant and staff safety. And then when it comes to the data, we've also thought a lot about what that means and have developed basically measures to track whether or not we're seeing significant disruption. And if there are periods where there's significant disruption, what we will do something is called administrative censoring, which means just those periods of time will be removed from the analysis. And we will only keep periods of time where we know that the data integrity are strong. And the primary analysis will therefore exclude those censored periods. But we just reviewed the data yesterday, and in fact, despite what we know on the ground, including in Hillbrow, is happening, you know, kind of, and the enormous disruption that's happening in our communities, the 084 sites are doing incredibly well to keep the clinic going. And it really is, I think, a testimony to the enormous commitment of the investigators, the communities, the participants, the cabs, that, you know, kind of that everyone knows how important it is to produce a result for women from this trial. And so we've been highly appreciative of the enormous commitments that people have demonstrated to keeping 084 going while keeping both staff and participants safe.
Thank you very much. And talking about the results, and as people expecting the results to see if does this drug work, should it get to be rolled out, you know. Let's also touch more on the accessibility of the drug. Should it, of course, get rolled out? Should the trial go through successfully? Should we find out that actually CAB-LA does work within women, you know, it's effective, it's working? Do you guys perhaps have a plan onto how will the drug be accessible to these young women that were participating in the study, and also for other young women such as me who would basically love and wish to basically have that drug? Do you perhaps have a plan on how the accessibility of the drug will be?
So that's a great question. It's something we think about when we start a trial, because we don't want to ask a question and then not be able to kind of provide access once that question is answered. There are a couple of parts to that process. The first is, let's assume we have an experience like 083. We get to a DSMB sometime in the future and they say, you've met the requirements for superiority. We suggest you unblind all participants, and then, you know, kind of, and communicate the results. What would happen is that we would do exactly that. We would offer unblinding to all participants. We have proposed a next step, which, like 083, would be an open label extension, during which we would offer people the opportunity to access cabotegravir. This is a way to allow post-trial access, at least to that group that you identified, the participants, while the process has gone through to basically license the product. The idea that the people who will do that licensing are ViiV Healthcare, the people who make cabotegravir, and they, you know, kind of, I think, anticipate in some areas it would take around 2 years or more to kind of get that license. A lot of work has been done to kind of prime regulatory and licensure authorities. And then, you know, it would become a question really for normative groups like WHO, as well as in-country policy, to decide how to incorporate CAB into its program. And obviously this superiority result makes an important argument for adding CAB into a program as an alternative or in addition to some of the other products that have shown benefit. So that's the process. So during the initial stages, we would try to provide post-trial access to people in the trial. There is the possibility that with demonstration projects, people who weren't in the trial could also join, and then eventually it should become part of a national program. And that timeline, I think, because everyone sees the importance of reducing HIV infection in women, could be shortened as much as possible, but it's still not an overnight process and might take several years.
Thank you very much for that, Dr. Sinead. Well, I guess I'll be giving this time to anyone who's within the meeting and who would like to basically raise a concern or ask a question. So you can just raise your hand and then I will be able to mute you. So I guess we're just gonna wait. Okay, there is one. All right, I'm unmuting you now.
Hi, Sinead. This is Sandra from AVAC. Just, do you know when you're gonna have the first conclusive results? I guess, like when, you know, the DSMB that's going to say, okay, we see something now, or what's the timeline you're looking at?
So Sandra, that's a great question, because it reminds me to tell everyone that as the protocol chair, we are blinded to the incidence rate. We, kind of are not privy to all the details of accumulating infections. And that's in order to kind of maintain, to avoid any biases. So we planning a November DSMB. This is scheduled. It will be the point at which data is reviewed. And those DSMBs happen every 6 months. Originally, the trial was scheduled to provide results in 2021 or 2022. But, I think everyone hopes that what we saw in 083 will be repeated in 084. So the earliest time point we could get a signal would be November. But on some of these things, I am superstitious, and so I don't want to jinx anything. And we'll just say that we're making sure that we are able to get to November despite the COVID disruption, and then we'll take things from there.
Great, thank you.
Thank you very much. Is there anyone else with a question or concern? Okay, going once, going twice. Okay, so it looks like I don't see anyone who has raised their hands up right now. Yes, I do not see anyone. And then from the panelist list, is there anyone who would like to share a question or raise any concern as well? Okay, there's also no one else there. Thank you very much. Thank you very much. So I guess moving on forward from now, the only thing that I would say is that I, as a young woman, I'm basically looking forward to the trial, basically coming to, let me just say, for us to receive the results of whether this drug does work, CAP-LA or not. I'm really looking forward to that and looking to the rolling out of the drug so that young women around my community can basically have access to this, because we really need this. We really do need this. I'm talking for myself as well. It's very, very, very essential, especially at this day and age that we're living in. And then to close it off, thank you very much, Dr. Sinead and your team, for asking me to be part of this. So we will be awaiting to hear more about the updating of the study within our next meetings and so on.
Well,
so
thank you very much.
Do I hand over to Melissa, or what do I do?
Well, maybe before you hand over, I just want to say thank you very much, Awelani. You did a fantastic job, although you do keep reminding me that you're a young woman and I'm a slightly older woman. But I think what we want are products for all women during all stages of the life course, so that we can prevent HIV infection. So some of those who've lived longer are more than happy to do the work to identify these new products.
Thank you very much. So I guess I'll hand over to Melissa.
Hey, Melissa.
Yeah, thank you so much. Hi, Sinead. Thank you so much for agreeing to be part of this conversation, and Awelani as well for leading us and sharing your insights and your questions as a young woman. We are grateful. We hope everyone who was able to join learned a lot from this session. And I will also just mention that we still have more conversations that are going to happen on the research literacy zone. So check out Engage and our Facebook pages where we have posted the times for the next sessions. So thank you very much everyone for joining. We look forward to seeing you in the next sessions. Bye.
Thank you, everyone.
Bye.
Take care, stay safe.